Hello, everyone. This is Dr. Sri Banerjee, and I am professor and core faculty at Walden University School of Health Sciences. Um, I, on a daily basis, teach doctoral level students and also conduct original research. Today, I'll be presenting on research that I conducted with my colleagues on the association between suicidal ideation and cardiovascular mortality in postmenopausal women. But before we get started, we would like to say that we have no financial disclosure or conflicts of interest to present. Just for completeness, we have provided here the abstract, and so you could go ahead and um, take a quick look into this. Here is a distribution of suicide in the global scene. And so you can probably take a look at where your country stands in relation to others when it comes to deaths from suicide in 2017. I also wanted to start off by talking about the definition. And the first person to really describe suicide was Emil Durkheim. And back in 1857, he said that the termination of an individual's life resulting directly or indirectly from a positive or negative act of the victim himself, which he knows will produce this fatal result. I also wanted to talk about some of the epidemiology that is um, related to suicide. Of course, in the United States, it's considered the 10th leading cause of death for all ages, over 30,000 deaths per year, and actually accounts for 1 to 2% of all deaths. So most common type of suicide is by firearms. However, hanging is the second most common for men, and then drug overdose is actually second most common for women. So here are some connections between suicide and cardiovascular disease that we already know. First of all, suicide attempters in one study by Wilson et al. Had a lower cumulative heart rate variability during the task than non-attempters, which is something to keep in mind. Increase in anger was greater in attempters and negatively associated with heart rate variability. And then attempters showed a reduced capacity to regulate the physiological stress response. So these are some important connections between suicidal ideation, attempters, and how physiologically cardiovascular changes take place. I'll be describing this a bit more in subsequent slides. Okay, so what are some additional connections between menopause and cardiovascular disease? Taking a look at that angle. So premenopausal women were protected from cardiovascular morbidity in the same way that age-matched men were. Um, in fact, not only same way, but even more so than age-matched men. However, following menopause, the risk of heart disease increases in women. So the hypotheses are that endogenous estrogens are cardioprotective, and the replacement of these estrogens in postmenopausal women would decrease the occurrence of heart disease in the population. So, whereas this theory has been supported by observational and animal studies, the usefulness of estrogen replacement therapy, recent large-scale clinical trials have failed to demonstrate cardioprotection with postmenopausal hormone replacement therapy. So, in a nutshell, the verdict is out as to the effect of estrogen. So, heart and estrogen progesterone replacement therapy study, HERS, and the WHI have reported adverse cardiovascular outcomes in subjects given supplemental estrogen. Um, again, there's a number of theories as to why these trials failed, but one of them is that maybe the age of HRT therapy onset varied. Also, maybe the formulation and duration of the pharmaceuticals might have been confounding variables, um, which might have explained some of the variations. Okay, so given all of this information, we decided that we were going to look at a nationally representative data set. Now, National Health and Nutrition Examination Survey is such a nationally representative data set, and so these were the criteria that we used. So when women greater than or equal to years of age 18, they all completed a reproductive health questionnaire. So they were all asked, have you had at least one menstrual period in the past 12 months? And of course, this doesn't include bleeding from medical conditions or hormone therapy, so on and so forth. Women who answered no were subsequently asked, what is the reason that you have not had a period in the past 12 months? And so we classified women as premenopausal if they answered yes to the first question or answered no to the first question, but indicated the reason as pregnancy, breastfeeding, irregular periods, etc. And then we classified women as postmenopausal if they answered no to the first question and indicated the reason to be uh have to be postmenopausal was because of natural menopause or hysterectomy. So again, we used the National Health and Nutrition Examination Survey between the years 2005 and 2010 and followed this up through December 2015. And so we documented cases of self-reported history of suicidal ideation and also found that CVD mortality outcomes of all-cause mortality, um, which individuals resulted in CVD mortality. Um, so here, um, the the red box indicates the area that is the question on suicidal ideation. That thoughts that you would be better off dead or of hurting yourself in some way. This is part of the PHQ-9, and over the past 2 weeks, this is assessed. So this is the model. Um, the connection between suicidal ideation and CVD mortality we assessed, and then furthermore, tried to see if menopausal status actually made a difference there. So these are all the results, and I'm going to go into a little bit more detail. So this shows, very importantly, that um, in fact, when individuals were postmenopausal and had suicidal ideation, they had 6.55 times likelihood of increased mortality than individuals that did not have suicidal ideation. The implications of this are very important. And so in comparison, when we looked at all women, regardless of menopausal status, the significant the relationship was not significant. So this shows that suicidal ideation is an important predictor of cardiovascular mortality. So there is something going on between suicidal ideation and cardiomyocytes. And so on a molecular level, it's interesting to see that there's some gaseous signaling going on, which is decreasing apoptosis. So estrogen has these gaseous signaling molecules, which has an effect on the heart. So as this diagram shows, you can see that there's apoptosis going on, hypertrophy that is decreasing. There's hypertrophy remodeling, which is decreasing. Relaxation is decreasing. and arrhythmias are decreasing. So in this figure, it shows how you can have certain signaling take place as a result of cardiomyocyte protection and results in cardiomyocyte protection. So let's go into a little bit more detail as to how estrogen is cardioprotective. So estrogen, the primary female sex hormone, improves cardiovascular function through the receptors, specifically the ER alpha, estrogen receptor beta, and G protein coupled estrogen receptor. So these are nucleus and outside the nucleus mediated changes. So gaseous signaling molecules like nitric oxide, hydrogen sulfide, carbon monoxide, these are important regulators of cardiovascular function and are being regulated by estrogen. So recent studies have demonstrated that estrogen regulates the production of these signaling molecules in cardiovascular cells. So maybe supplementation of gaseous donors may improve estrogen replacement therapy in postmenopausal cardiovascular disease. So in conclusion, our research indicates that suicide ideation leads to higher mortality. A significant association between suicidal ideation and CVD mortality was found in this population. And very importantly, this was independent of depression. So depression was a confounding variable that was controlled for. And even after that, among postmenopausal women, suicidal ideation led to higher cardiovascular mortality. Therapeutically, addressing menopausal symptoms can simultaneously address depression, suicide, and cardiovascular symptoms. Improved identification of suicidal threat, increased surveillance efforts, and addressing issues with health equity are needed to improve survival. Thank you for listening.